Hello, my name is Eileen Bautista, and I am a student nurse at West Coast University. Today, I will be presenting a research study on the prevention of hospital administrations. Let's begin. In today's agenda, I will be discussing a brief overview of hospital readmissions, the history of reporting readmission rates, the statistics on Medicare and Medicaid patients and their conditions for their readmissions, the cause of these readmissions, and recommendations to correct the problem. First, what is hospital readmission? A readmission is defined as hospitalization that occurs shortly after discharge from an initial hospitalization, regardless of the reason for the readmission. This is usually measured within 30 days. Readmissions are often, but not always, related to the problem inadequately resolved in the prior hospitalization, like a hospital-acquired infection. They can also be caused by the deterioration in a patient's health due to inadequate management of their condition. Therefore, interventions to reduce readmissions target both inpatient care through the efforts to improve the quality and safety of care, and the transition to outpatient care through the efforts to ensure the continuity and coordination between providers and timely access to need follow-up services. Here is a brief history of how readmission rates gained its importance in healthcare. In 2009, hospitals began voluntarily reporting hospital readmission rates to the Centers of Medicare and Medicaid Services for public review on their website. Rates for readmission occurring for any reason following hospitalization for one of three conditions: heart attack, heart failure, and pneumonia. In the Patient Protection and Affordable Care Act, Congress enacted the Hospital Readmission Reduction Program, HRRP, under which Medicare will penalize hospitals for higher than expected rates of readmission beginning in 2013. Its aim is to improve quality and reduce cost by reducing readmissions, but not all readmissions can be avoided. Now, here are some statistics on Medicare patients. 1/5 of Medicare beneficiaries, which is approximately 2 million beneficiaries per year, are discharged from a hospital return within 30 days, according to the Medicare Payment Advisory Commission. Some are unplanned, planned, and others are unrelated to the initial reason the patient came to the hospital. This costs the federal government $17.4 billion per year. By identifying and reducing avoidable readmissions, we will improve patient safety, enhance quality of care, and lower healthcare spending. Medicare patients account for more than 55% of all readmissions and 58% of costs associated with readmissions. The top 5 conditions with the most Medicare readmissions in 2011 were congestive heart failure, septicemia, pneumonia, chronic obstructive pulmonary disease, and cardiac dysrhythmias. Medicaid patients accounted for 20.6% of all readmissions and 18.4% of the associated costs. The 5 conditions with the most Medicaid readmissions in 2011 were mood disorders, schizophrenia and other psychotic disorders, diabetes mellitus, complications of pregnancy, and alcohol-related disorders. As we can see here in this chart, heart failure, followed by COPD, cardiovascular disease, pneumonia, and heart attack are the top readmissions in the hospital during 2012. Now, what are the causes of hospital readmissions? Patients with comorbidities are at risk for rehospitalization. An analysis of adults hospitalized in 6 states found that the higher the number of chronic conditions a patient had, the greater the chance of readmission. Another study has found that patients readmitted after being hospitalized with heart failure were more likely to have diabetes, peripheral vascular disease, stroke, and coronary artery disease. Language barriers also lead to a great risk of readmission because patients and their families are less likely to understand their diagnosis, medical reconciliation, and discharge instructions on ways to care for their condition and to prevent them from returning to the hospital. In a study, more than 7,000 patients were admitted to a Northern California hospital. Latino and Chinese patients who did not speak English were significantly more likely to be readmitted within 30 days than English speakers. Many patients may have not understood how and when to take medications, and many are unaware of the right dose and their adverse effects. There is also a lack of assessment regarding the follow-up of their discharge instructions, including the understanding of any change in medication and education of self-care. There is a lack of assessment of patients' home environment and resources such as transportation, equipment, and food. Patient and family engagement is important to help coach the patient into following discharge care. If there is a lack of this, it can lead to social issues such as depression. Psychological conditions like depression can affect patient recovery and increase the likelihood of readmission. Following hospitalization for a disease such as coronary artery disease, distressed patients were found to have significantly higher rates of readmission within 6 months than non-distressed patients. There may be patients who do not have a support system that will help them through their health conditions, sending them back to the hospital. There is also a lack of formal transition to community provider or hospital to follow up and ensure primary care appointment. Some patients may not adhere to post-discharge appointments and follow-up calls from their healthcare provider, which may lead to possible readmission. Now, how can we reduce readmission in the hospital? First, we must invest in quality. Care for the patients correctly and readmission rates fall and performance on quality measures improve. Healthcare professionals must work as an interdisciplinary team to ensure that the patient is on the road to recovery with the maximum use of resources. This includes the registered nurse, case manager, physician, social worker, and so on. The use of health information technology, such as electronic health records, patient registries, and risk stratification software, is also a great way to improve quality and integrate care across settings. We must begin care management and discharge planning early, target high-risk patients, and ensure frequent communication across the care team. We must maintain a lifeline with high-risk patients after discharge through telephone calls, telemonitoring, or other practices. We must align hospital efforts with those of the community providers to provide a range of care. Cooperation can be facilitated through collaborative relationships between hospital and community providers. Some solutions to reduce hospital readmission include educating the patient about his or her diagnosis throughout hospital stay, make appointments for clinician follow-up and test result follow-up. Patients should be educated along with their families in managing conditions, teach at a level appropriate to patients, and ensure that they understand and can teach back key instructions. We should confirm a medication plan because poor medication adherence leads to poor health outcomes and increased health costs. Give patients a written discharge plan and assess the patient's understanding of the plan. Tell the patient what to do if a problem arises, like if they have an adverse effect, to call their doctor. With these recommendations, we would be able to improve patient care and education, which would in turn reduce hospital readmission rates. In conclusion, I have explained a brief overview of hospital readmissions and how it has impacted our economy. We must work on preventing the rise of readmissions through interdisciplinary care and follow-up. Thank you for your time, and I hope you enjoyed my presentation.